Our first is Dr. Joel Pekow. He is an assistant professor of medicine at the University of Chicago, where he is also the co-director of the Integrated Translational Research Core. He attended the University of Illinois College of Medicine before pursuing a residency in internal medicine at Mass General Hospital, and is fellowship trained in gastroenterology at the University of Chicago's hospitals, where he remains as faculty. And of a side note, also was a year ahead of me in high school. So without further ado, Dr. Pekow.
My name is Joel Pekow. I'm a gastroenterologist, as was mentioned, from the University of Chicago. It's really a pleasure to be here today. My clinical expertise is in inflammatory bowel disease, but I spend a fair amount of time doing research in IBD-associated colon cancer, as well as chemoprevention for colon cancer. I'm going to talk to you about updates in colon cancer screening today. So just as a way of disclosure, I do have grant funding from Takeda and AbbVie. So this is somewhat of a dry talk, at least at the beginning. So I made a brief attempt to try and spruce this thing up by putting some images in here. But the first image that came up when I Googled colon was none other than Roberto Colon, the aging yet effective pitcher for the New York Mets. And although I'd love to go into a diatribe about baseball and my beloved Cubs, I didn't think it would go over very well with this audience. So we'll really focus on the task at hand here. And so what I'm going to do is I'm going to talk very briefly about some recent trends in colon cancer epidemiology, and then I'll go into more detail on colon cancer screening options and the data behind those options and why they're recommended, as well as kind of go over in more detail the newest recommendations from the U.S. Preventive Task Force. And then I'm going to talk about recommendations for surveillance after somebody has a cancer resected or a polyp removed. And then we'll get a little bit into talking about colonoscopy quality and measures we can do to improve the quality of screening, and as well as screening in high-risk patients. These are patients with a familial syndrome or patients with inflammatory bowel disease. And I'll finish up by talking about chemoprevention and some new U.S. Preventive Task Force recommendations for chemoprevention for colon cancer. So some recent trends in colon cancer epidemiology. So this study is looking at a trend in colon cancer mortality from 1970 to 2011. And as you can see nicely, there's a markedly decreased trend in colon cancer mortality. And this kind of mirrors colon cancer incidence. Just for reference, colonoscopy first was invented, so to speak, in 1969, but obviously only used for diagnostic purposes initially, and had increasing use in the 1990s with Medicare coverage in 2001, when we're starting to see the greatest decline in the rates of colonoscopy. But coupled with improved screening practices, there's also been improvement in surgical technique and chemotherapy that have led to this decline. So, but even with this declining rates in colon cancer incidence, you can see certain areas of the country, namely the Midwest, and not proudly the state I'm from, Illinois, it continues to have high rates of colon cancer. And on the flip side, when you look at the West Coast and specifically the Northeast, there's lower rates of colon cancer incidence. As would be expected, when you look at more detail of the counties that have higher incidences of colon cancer, these are more rural counties outside of urban areas, kind of in particular along the Mississippi River Valley, but also close to here in Kentucky as well. And then if you interpose this map with the rates of screening in the population, there's this inverse correlation. So there tends to be areas with high incidences of colon cancer tend to have low rates of screening, and it's estimated that over 20 million Americans who should have been screened still have never undergone colon cancer screening. And this does not even include patients who have had screening who are not up to date with their colon cancer screening. So we still have a lot of work to do because of the effectiveness of screening and further decreasing colon cancer incidence in the population as a whole. So to go into more detail about colon cancer screening options, so I kind of divided this into 4 main groups. So endoscopy, which includes flexible sigmoidoscopy and colonoscopy, imaging, which most of the good data supports CT colonography. Previously, we used barium enemas, which are less frequently used this day and age, although sometimes we'll use these in a patient who has an incomplete colonoscopy. There's a new blood test looking at a methylation marker that was recently FDA approved, and there's several stool-based tests that I'm going to go into more detail about. So first off, who should be screened? And this is talking about average risk population. So these are patients without a family history of colon cancer or obviously a hereditary colon cancer syndrome. So anybody age 50 to 75 should undergo screening. And then the U.S. Preventive Task Force kind of gives us gray area between age 76 and 85. So really an individualized approach based on the patient's comorbidities and life expectancy, which in clinical practice is really hard to predict. And then they recommend against screening over age 85. But keep in mind, this is not patients with a history of polyps. These are patients who have had a negative screening test before or who have never been screened. Stool-based tests should generally be performed every year, and the direct visualization test every 5 to 10 years, with 5-year intervals being recommended for flexible sigmoidoscopy, 10-year and CT colonography, and a 10-year interval for colonoscopy. There is this option to do a flexible sigmoidoscopy every 10 years with a fecal immunochemical testing every year as well that the U.S. Preventive Task Force recommends. So just to start off about guaiac-based tests, and I show this picture here. I'm sure some of you have nightmares about your medical school or residency with these guaiac-based tests. So essentially the guaiac-based test detects hemoglobin through a peroxidase reaction, and this turns this guaiac impregnated paper blue. So hemoglobin is not necessarily specific to blood loss from the colon. It can be found, it can result in a positive test from an upper GI source, but also certain foods, specifically red meat or rare meat, will cause a false positive with these tests. The other thing to note is that some foods result in a peroxidase reaction. These include turnips and broccoli and cantaloupe, amongst others. There's been several generations of this test. Probably the most widely studied is the Hemocult 2 test. This was studied in a randomized study of over 45,000 adults in Minnesota who were of screening age 50 to 80, and they were screened with either yearly guaiac-based tests, every other year test, or no screening for 2 6-year intervals. And this study showed that colon cancer mortality was decreased in the group that underwent screening by about 1/3. And in follow-up, there was a recently published study in the New England Journal of Medicine that showed that there was a reduced colon cancer mortality at 30 years as well. There was no change in overall mortality, but as you can imagine, we're looking at patients who were 50 to 80 years old and followed for 30 years. So the majority of patients in this study had died from various causes. These results have been validated in other studies in Europe showing a decrease in colon cancer mortality, although to a lesser degree. There's also a newer generation Hemocult test called the Sensa test that is more sensitive, although less specific than the Hemocult 2 test. And this is a figure from that Minnesota colon cancer study where you see that the patients who underwent annual screening with the guaiac-based test had less deaths from colon cancer than those who underwent every other year screening compared to those who did not undergo screening. So an effective modality for screening in the population. Kind of the next step up in tests are fecal immunochemical tests, and these detect globulin in the stool. And this has the advantage because globulin is absorbed in the proximal GI tract. This has the advantage of not resulting in positive tests from upper GI loss, and also foods that contain peroxidase do not result in false positive tests. This is more sensitive than the fecal blood test for the detection of adenomas, advanced adenomas, and colon cancer, although keep in mind that the detection with this test for adenomas and advanced adenomas is still relatively poor. If you look at this ROC analysis on the bottom, looking at a meta-analysis of all randomized studies performing the fecal immunochemical test, you can see a very good specificity of 0.94 and a sensitivity of 0.79. So also a very good screening test. And then the newest generation stool test is a multi-target stool DNA test, and this in a lot of ways is superior to the fecal immunochemical test alone. This test includes tests for promoter methylation of BMP3, NDRG4, as well as mutant KRAS. It includes beta-actin as a control, and then it also includes the immunochemical test within the testing panel. And if you look at this figure from this 2014 study in the New England Journal of Medicine, the detection rate with this multi-targeted stool DNA test, especially for early stage colon cancers, is superior to the FIT test alone, and it's also superior in the detection of either high-grade dysplasia or sessile serrated adenomas. Although overall, compared to colonoscopy, the sensitivity is still not great with the detection of high-grade dysplasia or sessile serrated adenomas. This was FDA approved, this panel called the Cologuard test, in August of 2014. The interval of testing with this panel is still not well known. The U.S. Preventive Task Force recommends every 1 to 3 year intervals of screening with this test, and it's approved by Medicare, although for screening at every 3-year intervals. More recently, this test looking at methylation of SEP9. SEP9 is a protein that's involved in endovesicular trafficking, also has a role in cellular apoptosis, and has been implicated in several studies in investigating carcinogenesis as well. This study looked at a blood-based marker of methylation of SEP9 for detection of colon cancer. And you can see, looking here, the overall detection rate for colon cancer is decent, but not as great as the stool-based test. But obviously, but it has a pretty good specificity of 91.5%, and obviously there's some advantages in certain populations for being able to do a blood-based test for screening. And so this was FDA approved, but by a very narrow margin in April of this year. It goes by the name of EpiProColon. This still is not on the U.S. Preventive Task Force recommendations at this point in time. The recommendations came out in June of 2016, so it's not clear if it wasn't recommended because the effectiveness is less than the other tests, or if it just was FDA approved so recently before the guidelines came out. So what about direct visualization tests? Let's start with CT colonography. The main indication for CT colonography is screening for colon cancer in average risk individuals over age 50. It can also be used for patients with a known colon cancer who have a contraindication to performing a colonoscopy to look for synchronous lesions before surgery. We'll oftentimes use this in patients who have an incomplete colonoscopy as well to evaluate the portion of the colon that was not fully evaluated by a colonoscopy. This procedure does require a bowel perforation. It requires insertion of a rectal tube with air insufflation of the colon and no sedation. And for that reason, sometimes patients aren't completely satisfied with this procedure because it can be somewhat uncomfortable to have your colon insufflated with air without sedation, although it's a relatively quick test. Depending on the center, there may be an infrastructure in place if a polyp is seen on the CT colonography to go right to colonoscopy the same day without taking 2 preps, but not all centers have the methodology in place. And oftentimes patients will need to take 2 preps, one to identify a polyp, and secondly to undergo colonoscopy and validate that a polyp is there and then remove the polyp. This is data from probably the largest study that has looked at CT colonography that was published in 2007, comparing randomizing patients to CT colonography or optical colonoscopy. You can see that the detection rate for advanced adenomas is equal amongst the 2 groups. In fact, there were more invasive cancers identified in the primary CT colonography group. That's probably more due to the low number of cancers in this population than an actual improved detection, as when you look at the total number of advanced neoplastic lesions, they're similar between the 2 groups. When you look overall at the number of polyp or adenomatous polyps that were resected, it was much greater in the optical colonoscopy group, although really where there was a difference was in polyps less than 6 millimeters in size, as polyps less than 6 millimeters in size are not well detected by CT scan. And it's debatable, honestly, whether these small polyps have the same precancerous or same cancerous potential over time as larger polyps. So the colonic perforation is pretty unusual with this test. Depending who you talk to, if this is a good or a bad thing, if you're talking to the radiologist or the patient, you can find incidental extracolonic findings on this test, which do necessitate further workup frequently. Obviously, with a CT scan, there's radiation exposure, about 7 to 8 millisieverts. So it's estimated that if you performed this screening test every 5 years from a patient who is age 50 to age 80, if you screened 100,000 individuals, it would result in 150 extra radiation-induced cancers. So moving on to endoscopy. So what about flexible sigmoidoscopy? Until recently, there wasn't a lot of good data regarding endoscopy and improvement in colon cancer mortality, but there's been several studies recently that have demonstrated an improvement. This is a Norwegian study looking at one-time only flexible sigmoidoscopy randomized in 100,000 individuals to the flexible sigmoidoscopy or no screening. And you can see that the patients who underwent flexible sigmoidoscopy had a significant improvement in incidence of colon cancer as well as mortality with long-term follow-up where you start to see this difference at about 8 years after their screening. How does this compare to colonoscopy? Well, there's no randomized control trials comparing flexible sigmoidoscopy to colonoscopy. This is data from 2 large cohort studies, the Nurses Health Study and the Health Professionals Study, where they followed health professionals for a number of years. And those that had a flexible sigmoidoscopy or a colonoscopy compared to no screening had a decrease in deaths from colon cancer, with colonoscopy being superior. When you look at the deaths from proximal colon cancers, these are the cancers on the right side of the colon, it's markedly decreased with colonoscopy, although not changed as would be expected from a flexible sigmoidoscopy. And then the deaths from distal colon cancers were also more markedly changed from colonoscopy than from flexible sigmoidoscopy. And this is pretty consistent with other studies where colonoscopy has a greater decrease in the rate of incidence and death from colon cancer for distal colon cancers than proximal colon cancers. I'm going to go over the possible reasons for that on a subsequent slide. So what happens when we take out an adenomatous polyp? So this is data from a study called the National Polyp Study, and when you looking at patients who had a polyp removed or no polyps removed and their incidence of colon cancer mortality with time, you can see that patients who had a polyp removed had a significantly decreased risk of colon cancer mortality with time, as would be expected. When you look at the group that did not have a polyp removed, these patients actually did the best, which if you think about it is what you would expect, because we know that polyp formers tend to form other polyps that can be either missed at colonoscopy or occur in an interval after the colonoscopy that puts them at risk over time for colon cancer. So just to cover some of the risks of colonoscopy, as there are several. Overall, the complications are rare, about 2 to 3 per 1,000 patients who have the procedure done. Mortality is exceptionally rare with this procedure. Cardiopulmonary complications do occur. Most are transient and occur during the procedure. For unknown reasons, there's also a higher risk of cardiopulmonary complications up to 30 days after a colonoscopy is performed. Perforation occurs in about 1 in every 1,000 patients who has this procedure performed. It's more common, as would be expected, in patients who have polyps resected, because the polyps are cut out or with use of, typically with the use of extra electrocoagulation. And the risk of perforation increases with resection of polyp size. There's also this inverse correlation with endoscopist experience with perforation. Bleeding, there's really 2 variants. One is immediate bleeding that occurs during the procedure. This is what we typically prefer, is we can take care of it during the procedure. Delayed bleeding occurs from the burn site at the polyp resection site, and an ulceration at the site, and it can occur up to 2 weeks after the procedure. It's more common in patients who are on anticoagulation, although aspirin has not shown to increase this risk. For this reason, we recommend, and this differs between centers, but at our center we keep patients on aspirin before the procedure and after the procedure. There's also this rare entity called post-polypectomy electrocoagulation syndrome where a patient develops a transmural burn and typical signs of peritonitis. It has a benign course, although patients often need to be hospitalized and sometimes receive IV antibiotics. Infection is rare, although transient bacteremia may occur. So which leads us to kind of the big question is which tests to choose. And really all these tests that I mentioned are effective. It really comes down to the cost of the test, both in terms of both monetary cost and third-party payer coverage, as well as the potential risk to the patient with the benefit to the patient in preventing cancer and deaths from cancer with time. It should also be noted that some areas of the country some areas of the country are resource poor in terms of having available endoscopists to perform these procedures. And in that case, other screening options are oftentimes preferable. So what about surveillance? So this is really important because third-party payers are starting to crack down on performing endoscopic exams too frequently on patients outside of standard recommendations. So just to go through this table, for when you get a pathology report back and there's small left-sided hyperplastic polyps, these do not have cancerous potential, and the patients who have these should have standard screening intervals. For patients who have 1 to 2 small tubular adenomas, these are typically less than a centimeter in size. The recommendations are 5 to 10 years after initial polypectomy, although most frequently we'll have patients come back at a 5-year interval, as we know that patients who have 1 polyp are more likely to have others, and it's fairly easy to miss small polyps with a colonoscopy. When a patient has over 3 adenomas, or an adenoma over 1 centimeter in size, or high-grade features on histology, they should have a follow-up colonoscopy in 3 years. And then if a patient has over 10 adenomas, we'll typically repeat a colonoscopy within a year. And for patients who have over 10 adenomas, I'll oftentimes refer them for genetic testing by a familial cancer specialist. For patients who have a sessile adenoma, so sessile or flat adenoma that's removed piecemeal, and these are typically larger than 2 centimeters in size, it's recommended to repeat a colonoscopy in 2 to 5 months. So what about after a patient has a cancer resected? So it's recommended that a colonoscopy should be performed prior to surgery to rule out synchronous lesions in the colon, or if it's not possible because of an obstructing lesion, to perform a colonoscopy within 3 to 6 months after a curative resection. And then after that colonoscopy, a second colonoscopy should be performed 1 year later. And then the subsequent intervals that are recommended are 3 years and 5 years after the curative resection. Let me clarify that. They should be done 3 years and 5 years after the last colonoscopy. Patients with a localized rectal cancer who have undergone either surgery without a mesorectal excision, transanal local excision, or endoscopic submucosal dissection, it's recommended to perform local surveillance with a flexible sigmoidoscopy or an endoscopic ultrasound at 3 to 6 months intervals for 2 to 3 years. So what about sessile serrated adenomas? And this can be a little bit confusing, as in the pathology world, the nomenclature of these polyps that we now refer to as sessile serrated adenomas changed about a decade ago, where there was some confusion if these were hyperplastic polyps or adenomas, and they had pathologists had different terms and several different terms for referring to these lesions. So they've really simplified things by either calling polyps either hyperplastic if they're serrated but do not have dysplastic features, or sessile serrated adenomas if they have serrated features on the polyp but it has dysplastic features. So these comprise about 8% of all polyps. The tricky thing about these polyps is they're mostly all located in the right colon, and they typically have a very flat appearance that can be difficult to distinguish the polyp from the surrounding mucosa, so it can be missed easily at the time of endoscopy. There's some clues that help us pick out what's a sessile serrated adenoma and what's just normal tissue. Oftentimes these reside on folds, and they'll oftentimes have mucus coating the stool. And with the universal acceptance of high definition colonoscopes, these have been easier to identify. These are often associated with DNA promoter hypermethylation, the SIMP pathway, rather than a chromosomal instability pathway. And the cancers that develop from these polyps frequently will have a BRAF mutation. These are not well detected, as I showed on the previous slide, by stool-based tests. And a key point is that for follow-up of these polyps, they should be treated like standard adenomas in terms of surveillance intervals. So in line with talking about these polyps, there's been a shift in colon cancer to having a greater proportion of right-sided cancers in the population. So why is this? There actually are not more right-sided cancers now, but the incidence of right-sided, the overall proportion of proximal cancers to distal cancers is increasing. There's several reasons why this might be. Flexible sigmoidoscopies obviously don't detect right-sided lesions. And then colonoscopy is likely not as good at detecting right-sided lesions from the data I showed earlier. This may be for several reasons. One, the prep quality oftentimes is not as good on the right side of the colon as it is on the left side of the colon. It can be difficult to look behind folds in the right side of the colon because the colonoscope, the movements of the colonoscope aren't as exact on the right side of the colon frequently as the left side of the colon as well. It's also possible that the biology of tumors in the right side is leading to a higher incidence, given that potentially there's changing environmental factors that are leading to a higher incidence of right-sided cancers, although this has not been well investigated. So this table on the bottom here is looking at interval cancers. So these are patients who had a negative colonoscopy and then had a cancer develop within 10 years. So if you look overall, the rate of interval cancers in the population is exceedingly low, but it is higher in patients who develop right-sided cancers than those who develop distal cancers, which kind of echoes the point that we may be missing more frequently right-sided lesions on endoscopy than left-sided lesions. So how can we improve our quality? So the one way is to give patients a split dose prep. And so when we're referring to split dose prep, we're referring to giving half the prep, typically half the prep, the night prior to the procedure and half the prep the morning of the procedure, or in some cases doing the whole prep the morning of the exam if a patient has an afternoon exam. There have been numerous randomized control trials looking at split dose prep compared to a single dose prep the night before the procedure, and the split dose prep is superior across these trials. And then when you look at the adenoma detection rate, the adenoma detection rate is kind of our marker of quality on an endoscopic exam. You can see that more polyps or more adenomas are detected when patients have a split dose prep rather than a single dose prep. And this holds true for both advanced adenomas and sessile serrated polyps as well. So if you're not doing a split dose prep when you refer patients for a colonoscopy, you should strongly consider giving patients split dose preparations. And some of the preps inherently such as the Osmo prep and the SU prep, are split dose preps. Oops. Sorry, I got a little ahead of myself there. So the other thing that we can do is to take more time looking. So it's been shown, and it took 40 years of colonoscopies to come up with this research, but patients, endoscopists who spend more time withdrawing the scope from the cecum to the anus detect more polyps, and there's less interval cancers or less interval cancers from endoscopists who spend more time in withdrawing the colonoscope. This study identified a sweet spot of 8 minutes for scope withdrawal. Other studies have shown 6 minutes, but it gets to the point that spending time having a quality exam and looking helps prevent subsequent cancers and detect more precancerous lesions. There's other factors that play a role as well, such as working with a fellow at the time of endoscopy, or doing morning procedures. And then there's several devices that are being developed and are commercially available but not widely used that can be placed on the colonoscope that help pull back the folds of the colon to get a better 360-degree view of the colon to detect more polyps as well. So let's go into screening in high-risk populations. Sorry for the picture after lunch. So just to talk about patients with a family history of colon cancer. So really the sweet spot in age of a family history in a first-degree relative is 60 years old. So if a patient has a first-degree relative who is less than 60 years old at the time of diagnosis of an adenoma or colon cancer, they should begin screening at age 40 or 10 years earlier than the their family member was diagnosed with their cancer. And they should undergo screening with colonoscopy every 5 years. The same holds true for patients who have over 2 first-degree relatives of any age with colon cancer. If a family member was over 60 when they were diagnosed with colon cancer, then you should begin screening at age 40, but the interval should be standard based on screening recommendations for the general population. Just to talk really briefly about high-risk populations, so patients with familial adenomatous polyposis, oftentimes these patients will have a genetic diagnosis, but if they do not and have a family member, a first-degree relative with FAP, they should begin screening at age 10 to 12 and have a flexible sigmoidoscopy every year to determine when polyps are forming. Patients with either a genetic diagnosis or a clinical diagnosis of hereditary non-polyposis colon cancer, or what we refer to as Lynch syndrome, should begin screening at age 20 to 25 or 10 years younger than the earliest case in the family and have a colonoscopy every 1 to 2 years. And then inflammatory bowel disease patients, these are patients with Crohn's colitis or ulcerative colitis. This does not include patients with Crohn's disease of the ileum, as they are not at increased risk for colon cancer. They should begin surveillance at 8 years of disease duration, and then a colonoscopy every 1 to 3 years, which I'm going to expound on a little bit more here. So, as most of you know, patients with IBD, so ulcerative colitis namely, but also Crohn's colitis, are at higher risk for the development of colon cancer. It was thought previously that this risk was markedly high. So there was a meta-analysis that came out in the late 90s that showed that the risk at 30 years disease duration was 18% in the population. We know from subsequent studies that this risk is actually markedly lower, but when you take patients who have long-standing disease, so over 10 years of disease duration, and their entire colon involved by colitis, they still have a 7 to 8 times increased risk of colon cancer compared to the general population. And there's several factors that increase one's risk. Probably the most marked is a co-diagnosis of primary sclerosing cholangitis. So for patients with PSC and IBD, we recommend doing surveillance at the time of diagnosis of PSC or IBD, whatever comes second, and every year thereafter because of this increased risk. As I mentioned, patients with longer standing disease and extensive colitis have a higher risk as well. Those with a family history and a first-degree relative are at increased risk. And we also know that patients who have poorly controlled inflammation, particularly for a long period of time, are at a higher risk as well. And there's certain endoscopic features, including a stricture in the colon, or what we refer to as post-inflammatory polyps or pseudopolyps that are not precancerous polyps but occur in the setting of inflammation. But these do place patients at increased risk for colon cancer who have IBD. So for patients who have these risk factors, we recommend more frequent surveillance, and oftentimes we'll use chromoendoscopy, which I'm going to show some examples of on a subsequent slide to increase our detection rate of polyps overall. So just to summarize the recommendations in this population, as it can be a little bit confusing. So anybody with ulcerative colitis who had either left-sided colitis or pancolitis should undergo a surveillance program for dysplasia and colon cancer. These recommendations do not apply to patients who have isolated proctitis. And then patients with Crohn's colitis who've had over a third of their colon involved by colitis should undergo a surveillance program as well. Patients with isolated ileal disease or a short segment of their colon, such as rectal inflammation, do not necessarily need to undergo surveillance for dysplasia in IBD. And the surveillance should begin at 8 to 10 years of disease duration for the majority of patients with IBD, because we know that the risk of cancer starts to increase at that point in time. Although 2 of the GI societies recommend beginning surveillance at 15 years of disease duration for patients who have isolated left-sided disease, as the risk of cancer development in that population is lower. And then the interval is really up to the physician every 1 to 3 years, and I base it based on that previous slide, based on a patient's individual risk factors of choosing a 1 to 3, a 1 year interval or a 3 year interval. It was previously thought that most dysplastic lesions in patients with IBD were invisible, so patients would have these precancerous changes in the colon that could not be seen at the time of endoscopy, and then all of a sudden develop a cancer. We know, and for that reason, the guidelines recommend doing 4-quadrant biopsies every 10 centimeters in the colon with targeted biopsies of visible lesions. We know now with high definition colonoscopes and chromoendoscopy that virtually all dysplastic lesions are visible. So there's a shift in the field moving away from these random biopsies of the colon to just looking and doing targeted biopsies. So this is an example of chromoendoscopy, which don't have time to go into significant detail here. What we essentially do is we spray a blue dye in the colon, either methylene blue or indigo carmine, and this helps pick out differentiate the pit pattern of a polyp to determine if it has dysplasia in it. It also helps identify the polyp and identify the borders of the polyp well. And studies have shown that with these dye-based methods of chromoendoscopy, there's a significant increased rate in detection of dysplasia. There's also dye-less methods, which involve an optical filter on the colonoscope. These have not been shown to increase the rate of dysplasia detection in IBD. And on these images here, you can see examples of this flat, kind of carpet-like lesion in the colon where you can't see the borders of the lesion very well compared to the surrounding mucosa, but you can tell that there's a dysplastic lesion there. And given the size and the fact that the borders couldn't be well demarcated, this patient needed surgery rather than endoscopic resection for the polyp. So just to finish up, I want to talk about chemoprevention, as there's some new recommendations by the U.S. Preventive Task Force for chemoprevention. So this is kind of my effort to summarize thousands of studies in chemoprevention in one slide here. So in terms of diet, in general, high fiber diets and low fat diets have not been shown to provide benefit in terms of colon cancer chemoprevention. High red meat has been shown to increase the risk of colon cancer when compared to patients with who have no red meat intake or very little red meat intake. Although there hasn't been studies looking at patients who have low red meat intake on a prospective study on actual prevention of colon cancer. So the data remains relatively weak. Vitamin D, there's been a lot of interest in looking at vitamin D, including from our group, and really there's inconsistent benefit, including a recent large randomized control trial looking at vitamin D on polyp formation, which did not show benefit. The same holds true for calcium, and folic acid has not been shown to provide a benefit in chemoprevention for colon cancer. Where we start to see a benefit is really in aspirins and other NSAIDs, which I'm going to go over on the subsequent slide. There's also been a lot of interest in looking at statins, but without a lot of data to support their use. So this figure here is a little bit hard to see. It's a meta-analysis looking at non-randomized control trials. On the top here, in patients who took aspirin, NSAIDs, or both, and on the bottom is looking at aspirin alone. And you can see that the odds ratio for development of colon cancer was about 0.7, so a significant decreased risk in patients who took aspirin or NSAIDs. And there's been 4 randomized control trials that have looked at low-dose aspirin on the development of colon cancer. These studies were not done with a primary outcome of looking at colon cancer. They were, for the most part, cardiovascular studies. This publication combined the results of those studies into a meta-analysis, and you can see across all studies looking at the top here with just short-term use, there's markedly decreased incidence over here as well as mortality related to colon cancer with low-dose aspirin use, and the same holds true for over 5 years of use of aspirin. In addition, there's been several randomized studies that have looked at the chemopreventive potential of aspirin in polyp formers on the prevention of new polyps. And you can see across these studies in terms of looking at adenomas and advanced lesions, there's a trend towards patients having less polyps with aspirin, especially with advanced lesions of a risk ratio of about 0.7 compared to those who took placebo. So the new recommendations as of June of this year, the U.S. Preventive Task Force does now recommend aspirin for chemo prevention of colon cancer, as well as primary prevention of cardiovascular disease in individuals with an over 10% cardiovascular disease risk and a low risk of bleeding who are willing to take it for at least 10 years. And the same holds true for patients aged 60 to 69, although they do recommend taking into account a patient's life expectancy and comorbidities at that point in time. So in summary, screening practices have decreased the overall incidence and mortality related to colon cancer in recent years. A large portion of the population has not been screened, and that's where we as health professionals can do a better job at getting out the word and screening our population to prevent the incidence of colon cancer. Colonoscopy is the best test for screening, although all approved methods of screening are effective and cost effective. So really the decision on what test to use is based on the cost and benefit to the patient and the available endoscopists in your area that you're practicing. And you should consider starting aspirin for chemoprevention, both in patients with a history of adenomas, those with a familial colon cancer syndrome, which I did not get into, as well as for primary prevention. So I wanted to thank you all for your attention. I know there was a lot to go over in a short period of time. And just to put a little bit of a plug in, we do have a CME on high-risk populations to kind of expound on some of what I said today in Chicago. If anybody's interested in going to Chicago in the middle of the winter in January of this year. Yes.
In my family, I had a sister die of other disease, but she did have cancer of the colon, so I couldn't screen. But somebody struck me. What about your children and grandchildren? Are they at greater risk?
So they are. So it really the recommendation. This is based on data showing increased risk. Is really it depends on how close the relative was to you, their age, and the number of relatives that you have. So for a first degree relative, if they were less than 60 when they had cancer or a polyp. So you know, to tell you the truth, if I'm doing an endoscopy on a patient, and they say their relative was 64 or 63, I still follow the less than 60 because I assume they developed an adenoma before age 60.
Children and grandchildren.
So children. So if they have over two second degree relatives, they are at higher risk. But one, they should not be at higher risk.
The other question is, in general, there are more and more chemicals being produced. I mean, even your car tires end up as fragments on the side of the road. And we're ingesting so many new chemicals because the manufacturers keep making new chemicals. Do you think we're at a greater risk as the years go on?
Well, that's a interesting point and a hot topic for research. We do know that there's been a lot of interest in our group in studying the colonic microbiome and its effect on both inflammation and cancer. And we do know that virtually everything alters the microbiome, so chemicals, food, medicines, so forth. And change in the microbiome, at least we haven't gotten to the point of linking those changes with the development of cancer or IBD, but at least in preclinical models and animal models, they do play a role. So it's likely a very complex answer to that question.
Thank you.
I'm glad you came to talk, and thank you for your talk and I was really interested in it with your background in IBD because there is so much inflammation associated with colon cancer formation. And I was glad you touched on the microbiome just now in the latest answer, because one thing I've heard in the past is the effect of changes in circadian rhythm, especially shift workers and alterations in sleep-wake cycle when people are eating, exposing their gut to the digestion process. And its effect, it seems to be pretty well known on IBD. It decreases inflammation. But last time I looked, the literature was kind of scant on whether it was generalizable to the entire population for a decrease in colon cancer risk.
Yeah, I do not know, I'm not sure if anybody else on the panel knows data. I do not know any data on shift workers and colon cancer risk overall, but it would be an interesting, it's an interesting, I'm sure somebody has looked at this in some degree. I just don't know the data behind it.
And then the I think it was SEP9, it might have been SEP7.
SEP9, yeah.
The SEP9 methylation was very interesting as well. It was the first I had heard of it. Do you know if they had any differences in detection of right-sided and left-sided cancers, if it was more sensitive for one side versus the other, as some of the other screening tests were? And if it, I know it was designed for colon cancer, but if it picked up other malignancies, associated malignancies.
Let me see. Yeah, we did. There's something on it. So I actually do not recall if there was I don't believe there was a difference by location in the colon. It was more based on the stage and the size of the cancer and the histologic grade of the cancer. And I don't know if this has been investigated with other cancers either. Sorry.
Thank you very much.
Thank you.